Hello guys, good evening. Um, I think today we'll be seeing about the FMG recently conducted July 2023 anatomy session. So this is basically a recall session where we have tried to collect as many as questions possible related to our topics, and we'll be discussing that today. See, this time FMG exams, if you see, uh, most of the questions were clinical oriented questions. Okay, so they were not direct questions, so they have put one or the other clinical scenarios, and they have asked the questions, and the options are based on that. Okay, see, once if they give these kind of clinical scenarios, you should know how to apply your basic science knowledge. Okay, so the basic sciences are like anatomy, physiology, and biochemistry. You should know how to apply them on the clinical side, and if you know to apply them, then the questions will be very easy, and you can easily get the answer. Okay, so these questions, though they are clinical oriented questions, I am telling you, these are not tough questions. Many questions this year were repeat questions. If you have done your previous year papers well, then I think you would have crack this exam well. Okay, so keep revising. That is my main message for the students. Okay, so keep revising, even the known things, even the simple things. If you don't revise, you are prone to you're prone to forget it. Okay, so please keep revising it. And I think without wasting much of the time, in this evening we'll go to the first question from the anatomy. Okay, so the first question goes like this. So the patient presented with a deformity of the hand as shown in the figure. Okay, and his x-ray picture is also shown. Okay, so they are asking what is the nerve that is most likely damaged. Okay, so there are few clues from the picture and from the x-ray what they have given. Okay, so first we'll analyze the picture and then we'll go to the options. Okay, so if you see this, okay, if you see this picture, what is this? This is wrist in flexion. Okay, the wrist is in flexion. Okay, in other words, the patient is not able to do, okay, not able to do, okay, wrist and finger extension, wrist and finger extension. Okay guys, so the wrist is in the state of flexion and finger is in a state of flexion. They were not able to extend it. So what is this attitude called as? This attitude is called as wrist drop. Okay, this attitude is called as a wrist drop, and along with that they are given an x-ray of the arm showing a fracture here. Okay, you can see a fracture here. Okay, so there is a fracture in the humeral shaft. There is a fracture in the humeral shaft. Okay, and this fracture is at the junction of, okay, it is at the junction of mid third and distal third of the humerus. Mid third, distal third junction, the fracture has happened. These kind of fractures are called as what? These are called as Holstein-Lewis fracture. So what is these fractures called as? These fractures are called as Holstein-Lewis fracture. Very important, frequently asked question from orthopedics. Okay, not related to anatomy, but from orthopedics, this question frequently comes. So what is this fracture? This fracture is called as a Holstein-Lewis fracture. Whenever there is a Holstein-Lewis fracture, the most common nerve that gets injured in this type of fracture is radial nerve. So what is this? This is radial. The radial nerve gets damaged whenever there is a Holstein-Lewis kind of fracture. And what kind of nerve injury happens to the radial nerve? Usually neuropraxia kind of injury happens. I hope you know there are three kinds of nerve injuries. Okay, one is called as neuropraxia, another one is called as axonotmesis, another one is called as neurotmesis. Okay, there are three kinds of nerve injuries. Of this, Holstein-Lewis fracture mostly causes neuropraxia kind of injury. And one more question in this: what is the most common cause of radial nerve palsy? Okay, the most common cause of radial nerve palsy is Holstein-Lewis fracture. Okay, so please guys have a clear picture about this area. Frequent questions come from this area. Okay, so whenever there is a Holstein-Lewis fracture, or whenever there is a humeral shaft fracture, the nerve that runs close to it, okay, the nerve that runs close to it behind the spiral groove is the radial nerve. So what is this nerve? This nerve is called as a radial nerve, and this nerve runs very close to the shaft of the humerus. Okay, so whenever there is a fracture, this nerve is prone to get injured. When this nerve get injured, the radial nerve supplies the extensors of the muscles. Okay, it supplies the extensors of the forearm. So what is the supply of radial nerve? So radial nerve supplies the extensors of the elbow. Okay, extensors of the elbow. Okay, and the extensors of the wrist and the extensors of the fingers. So these are all supplied by the radial nerve. Once the radial nerve gets damaged, these muscles become weak and the patient is not able to do wrist extension or finger extension. If it is a very high radial nerve palsy, the patient may not be able to do even elbow extension. Okay, so whenever a scenario like this is given to you, where there is a wrist drop along with an Halson-Lewis fracture, the answer is very, very simple and it stands in front of you. The answer is radial nerve. The answer is radial nerve. Okay, so with this, we'll move to the next question, guys. So the next question is again a clinical based question. So based on the inputs from the students, we have gathered some questions and we have slightly modified how they have framed the questions. Okay, so it may not be the same replica of what you have seen in the exam, but the topics are almost similar. Okay, see, in this, a person had a Fuchs injury and he has got anatomical box tenderness, anatomical snuff box tenderness. And what is the bone that is commonly? First of all, we'll analyze what is this Fuchs injury called. This Fuchs injury stands for fall on outstretched hand. Okay, the Fuchs injury stands for fall on an outstretched hand. Okay, fall on an outstretched hand. Okay, so the Fuchs stands for fall on an outstretched. Whenever a patient has got fall on an outstretched hand, lot of bones can get fractured, right from the scaphoid, right from the distal radius, from the fractures around the elbow to the fractures of the humerus and the clavicle. All this can occur due to a fall on an outstretched hand, which we call in a shorter form as Fuchs injury. But this patient classically present with tenderness in the anatomical snuff box. Okay, what is called as an anatomical snuff box? If you see my hand, you can see a depression here. You can see a depression here. This depression, which is seen in the wrist, on the lateral aspect of the wrist, is called as an anatomical snuff box. Okay, so if you take the anatomical snuff box is bounded by a certain tendons. Okay, so on the lateral side you get two tendons. Okay, and on the medial side you get one tendon, and on the medial side you get what? One tendon. Okay, so the two tendons on the lateral side are, okay, one is called as an abductor pollicis longus tendon, another one is called as an extensor pollicis brevis tendon, and the one which is on the medial side is called as an extensor pollicis longus tendon. Okay, so these are the two groups of tendons, okay, forming the boundaries of anatomical snuff box. Okay, if you see the roof of the anatomical snuff box, in the roof, apart from skin, superficial fascia, one important nerve runs in the roof. The nerve which runs in the roof of the anatomical snuff box is nothing but the superficial branch of radial nerve. Is nothing but the superficial branch of radial nerve. Okay, it's nothing but the superficial branch of radial nerve. Okay, it's nothing but the superficial branch of radial nerve. And if you take the floor of the, this is roof, if you take the floor of the anatomical snuff box, the floor of the anatomical snuff box is formed by the following bones. It is formed by the distal radius, it is formed by the scaphoid bone, okay, and it is formed a small part by trapezium and by the first metacarpal bone. Okay, so what are these bones? Okay, these bones are the distal radius, these bones are the distal radius, and this is scaphoid bone. Okay, and this is scaphoid bone, and this is the trapezium. Okay, and this is trapezium, and what is this? This is the first metacarpal bone. Okay, so all these bones lie in the floor of the anatomical snuff box. Of these, the most important bones are the distal radius and the scaphoid bone, Okay, so these are the things which forms the floor of the anatomical snuff box, and there is one important structure which runs in the anatomical snuff box, which is called as the content of the anatomical snuff box. That is nothing but the radial artery. So this is radial artery. Radial artery is the content of the anatomical snuff box. Okay, now if suppose a patient has got tenderness in this, any of this bone could have got fractured. Any of this bone could have got fractured. Preferably, most commonly, scaphoid bone is the one which gets fractured in this area, and the tenderness noted in the anatomical snub box is usually related to the scaphoid fracture. Okay, so the answer is very simple. It is scaphoid fracture. And always, guys, please remember, scaphoid fracture is one fracture which is more prone for non-union, and it is also more prone for avascular necrosis. Avascular necrosis. Okay, guys. So this is prone for avascular necrosis. Also remember the other bones like the neck of femur. Okay, the neck of femur fracture, and the talus neck fracture are also fractures which are more prone for avascular necrosis. This is again an MCQ in this area. The bones which commonly goes on for avascular necrosis are scaphoid, proximal femur, and the talus. These are the bones which commonly goes in for avascular necrosis. Okay, guys, please remember this. Okay, so for anatomical snub box, if you have got tenderness in the anatomical snub box, the answer is very simple. It is scaphoid bone. Okay, so with this, we'll move to the next question, guys. So the next question is again a clinical based question, guys. It's again a clinical based question. Now here the scenario what they given is a person had an RTA and he had suffered injury to bulbar urethra. What can be the location of collection of the urine due to this injury? Okay, see, first of all, if you see the urethra, okay, so let us consider this is the urinary bladder. This is the urinary bladder. The urinary bladder continues down as the urethra. Okay, so the urethra has got in the male urethra there are 3 parts in the male urethra. Okay, it has got 3 parts in the male urethra. One part which is surrounded by the prostate gland is called as a prostatic urethra. Is called as prostatic. This is called as what? This is called as prostatic urethra. Prostatic urethra. And the one which is surrounded by the urogenital diaphragm. Okay, the one which is surrounded by the urogenital diaphragm, okay, below the prostatic urethra, is called as the membranous urethra. So this portion is called as the membranous urethra. This portion is called as membranous urethra. And the one which is present below the membranous urethra, forming the bulb of the penis, lying within the bulb of the penis, is the bulbar urethra and the penile urethra. So this is bulbar urethra. This is bulbar urethra, and this part which is present in the shaft of the penis is called as the penile urethra. It's called as the penile urethra. Okay, so these are the parts of the urethra. Now the question is very simple. The patient had sustained injury to the bulbar urethra. Now where the urine can get collected into? For this, you should have an idea about the perineal pouches. Okay, I hope you know there are 2 perineal pouches. One is called as a superficial perineal pouch, another one is called as a deep perineal pouch. Okay, we'll just analyze this pouch. Okay, so if you take there is a bone called as pubic bone here. Okay, and in front you will have the skin. Okay, the skin will be continuous with the skin of the external genitalia. Okay, and posteriorly there is a perineal body which is a fibromuscular node which is present in the center of the perineum, which is called as a perineal body, guys. Okay, now deep to the skin, I hope you all know that there is an fascia which is called as fascia of Camper, or an fatty layer. Okay, and deep to it is the Scarpa's fascia. Okay, the Scarpa's fascia, when it comes to the penis, it forms the Buck's fascia. When it comes to the scrotum, it forms the Darta's fascia. Okay, and when it comes to the perineal region, it forms the Colles fascia. It forms the Colles fascia, guys. Okay, this Colles fascia goes and gets attached to an membrane which is called as a perineal membrane, which is present below the urogenital diaphragm. So there is a diaphragm here which is called as an urogenital diaphragm. Below the urogenital diaphragm, there is a membrane called as perineal membrane. Okay, I'll repeat. So what is this diaphragm called as? This diaphragm is called as urogenital diaphragm. This is called as urogenital diaphragm, guys. This is called as urogenital diaphragm, and this urogenital diaphragm is lined inferiorly by a membrane which is called as a perineal membrane, guys. Okay, so and this Colles fascia, which is present in the genital region, gets reflected on the anterior surface of the perineal body, and it fuses with the perineal membrane. It fuses with the perineal membrane. Okay, so above the urogenital diaphragm, okay, above the urogenital diaphragm, you have got a superior fascia of the urogenital diaphragm. So this is called as an superior fascia of the urogenital diaphragm. Superior fascia of urogenital diaphragm. Okay, so now you have got two pouches here. One pouch between the two membranes. Okay, so this pouch is called as an deep perineal pouch. This is called as a deep perineal pouch. Okay, and the pouch which is present below is called as an superficial perineal pouch. It is called as a superficial perineal pouch. Okay, superficial perineal pouch. Now, if you put the urethra in this area, okay, you can see the bladder sitting above the urogenital diaphragm. The prostatic urethra is coming here. The membranous urethra is passing through the urogenital diaphragm and through the deep perineal pouch. Then it pierces the perineal membrane, becomes the bulbar urethra, and then it continues as the penile urethra. Okay. Now, if an injury occurs here, the urine first collects into this pouch. Now, what is this pouch called as? This pouch is called a superficial perineal pouch, and this superficial perineal pouch is connected to the anterior abdominal wall. It is connected to the anterior abdominal wall. Okay. It is connected to the uppermost part of the thigh. It is connected to the uppermost part of the thigh. Okay. It is connected to the uppermost part of the thigh up to the Holden's line. Up to the Holden's line. Okay. Clear. And it is connected to the scrotum. Okay. And the penile area and to the penis. It is connected to the scrotum and the penile. So superficial perineal pouch is connected to all this. So if there is an injury to the bulbar urethra and the urine, if it is collected in the superficial perineal pouch, where it is going to reach? Yes. So the question is, so can it reach the inguinal pouch or the deep perineal pouch? No, it cannot reach the deep perineal pouch, because you can see here the superficial perineal pouch is closed posteriorly. It is not open to the deep perineal pouch. So it cannot go there. It cannot go to the peritoneal cavity. It cannot go to the ischiorectal fossa. Since the superficial perineal pouch is connected to the anterior abdominal wall, the appropriate answer for this question is anterior abdominal wall. Okay, guys. So things are very, very simple. If you understand the perineal pouches, this question has come in number of times. So if you understand the questions, then it is very, very easy to answer it. Okay, fine. So we'll go to the next topic, guys. Yes. So this patient again is a clinical based question where a patient has extraction of the third molar teeth, and after this the patient was observed to have loss of sensation from the anterior two-thirds of the tongue and floor of the mouth. What is the nerve that is most likely to be injured? Okay, so there are lot of clues which are given here. Here they have given extraction of the third molar tooth, following which there is loss of sensation from the anterior two-thirds of the tongue and from the floor of the mouth. Okay, if you want to put it straightforward, okay, so the anterior two-thirds of the tongue, if you see the tongue, so let us consider this is the tongue, this is the tongue. Okay, so the tongue is divided into anterior two-thirds and posterior one-third. Okay, the anterior two-thirds of the tongue, the general sensation is by lingual nerve, and special sensation is by carda tympani nerve, and how the carda tympani nerve reaches the tongue? It reaches via the lingual nerve. Okay, so the anterior two-thirds of the tongue, both the general sensation and the special sensation is through the lingual nerve. Special sensation through the fibers of carda tympani via the lingual nerve. Okay, so if the patient has got a decreased sensation in the anterior two-thirds of the tongue, okay, and along with decreased sensation in the floor of the mouth, which is again supplied by lingual nerve, the answer is very, very simple. It is lingual nerve. Okay, see, whenever they extract the teeth, they give injection close to the third molar teeth, just behind the molar teeth, where the lingual nerve runs very close to the ramus of the mandible. Okay, so if you see the ramus of the mandible, okay, so this is the body of the mandible, this is the ramus of the mandible, this is the coronoid process, the neck and the head of the mandible. Okay, so inside the mandible on the medial side, there is an teeth or a tongue-like projection called as lingula of the mandible. So medial side of the mandible, there is a nerve which runs very close to it. This nerve is nothing but the lingual nerve. So they give injection in this area to anesthetize the lingual nerve and also to anesthetize the inferior alveolar nerve which is close to it. Okay, which is close to it. Okay, so whenever there is a decreased sensation in the anterior two-thirds of the tongue, the answer is very simple, guys. It is lingual nerve. You can ask me, sir, what about hypoglossal nerve? What about hypoglossal nerve is the motor supply for the tongue. Okay, it supplies all the muscles of the tongue except one muscle. Okay, so can anybody tell me what is that muscle which is not supplied by the hypoglossal nerve? Hypoglossal nerve supplies all the muscles of the tongue. It supplies all muscles of the tongue, except palatoglossus. Okay, except palatoglossus. Okay, except palatoglossus, which is supplied by cranial accessory nerve, Okay, so the next option is accessory nerve. That is, let us consider this is cranial accessory nerve. Cranial accessory nerve supplies the palatoglossal muscle of the tongue region, whereas the lingual nerve is a sensory nerve. Okay, it is a sensory nerve. Okay, inferior alveolar nerve, if you take, it supplies the lower teeth. Okay, it supplies the lower teeth or the mandible. Okay, the teeth in the mandible are supplied by the inferior alveolar nerve. They have not discussed about inferior alveolar nerve in this. They have stopped their discussion with the tongue. So the right option for this is lingual nerve. Okay, so with this we'll move to the next question, guys. So the next question is, see, this question would have come 100 times. Okay, this would have come 100 times. One way or the other, it will come. So this is a very, very simple question again. A patient suffered from extradural hemorrhage due to involvement of middle meningeal artery. What can be the location of injury in this skull? Okay, so if you take the skull, the anterior portion of the skull where the two external occipital, where the two superciliary notch meets. Okay, this is called as an nasion. Okay, what is this called? This is called as a nasion. And the posterior most part of the skull where there is an external occipital protuberance, and the most prominent part of the external occipital protuberance is called as what? It is called as an inion. It is called as an inion. And the portion where the lambda sutures, okay, meet with the parietal sutures, are the junction of the parietal bone with the temporal bone and with the occipital bone. This area is called as an astrion. This area is called as an astrion. Okay, in a similar way, more anteriorly, where the parietal bone, the frontal bone, the temporal bone, and the greater wing of the sphenoid meets with one another, this area is called as pterion. This area is called as what? Pterion. And deep to the pterion, there are three important things noted. Okay, so one important structure deep to the pterion is the anterior division of the middle meningeal artery. So what is this, guys? This is the anterior division of middle meningeal artery. This is anterior division of middle meningeal artery. Okay, apart from this, okay, behind the pterion you have the lateral sulcus. You have the lateral sulcus of the brain. Okay, you have got the lateral sulcus of the, you have got the stem of the lateral sulcus of the brain. And behind the pterion is where the lesser wing of sphenoid ends. Lesser wing of sphenoid ends at the pterion. So these are the three important things related to pterion. So now whenever there is an injury to the pterion, what is the artery that is getting affected? It is middle meningeal artery. Middle meningeal artery is extradural in course. So whenever there is a middle meningeal artery rupture, it causes extradural hemorrhage. Extradural hemorrhage or hematoma. Okay, it causes extradural hematoma. Whenever there is an extradural hematoma, if you take a plain CT, okay, if you take a plain CT, you can see a lemon-shaped appearance of the hematoma. You can see a lemon-shaped appearance of the hematoma. And whenever there is an extradural hematoma, it is confined to the sutures. It is confined to the sutures of the skull. It is confined to the sutures of the skull. It cannot cross the sutures of the skull because of the attachment of the periosteum at the sutural lines. Because of the attachment of the periosteum at the suture lines. Okay, so if you take the radiological image, you can see a lemon shaped or a biconvex shape. Okay, lemon or biconvex shaped image in a plain CT. Okay, in a plain CT is diagnosis of extradural hematoma. Is diagnosis of extradural hematoma. If you take a banana shape, if you take a banana shaped lesion or a lens shaped lesion, okay, then the diagnosis is subarachnoid hemorrhage. Then the diagnosis is subarachnoid hemorrhage, guys. Okay, then the subdural hemorrhage, then that is subdural hemorrhage, then that is called a subdural hemorrhage. Okay, see now when you go back to the option, you can see that the location of injury to the skull where middle meningeal artery runs will be the pterion, guys, will be the pterion. Okay, so this question had come n number of times, so please pay attention to this question and don't make mistakes in repeat questions. Okay, yes. So now next again an procedure based question here. A needle has to be inserted by an intern into the pleural cavity, okay, preferably for aspirating the pleural fluid. And what is the most preferable site for inserting a needle in the intercostal space? Okay, so what they have given here is intercostal space. Okay, so if you see the intercostal space, okay, so this is the upper rib. Okay, this is the upper rib and this is the lower rib. Let us consider this is one intercostal space which is bounded by one upper rib and one lower rib. And if you see the intercostal spaces, you got lot of muscles here. You got external intercostal muscle which forms the outermost layer. Then comes the internal intercostal muscle. Then comes the innermost internal intercostal muscle. And in between the internal intercostal muscle and innermost internal intercostal muscle, you can see the neurovascular bundle. And these neurovascular bundles are running just beneath the ribs. They are running just beneath the ribs. Okay, they are running just beneath the ribs in the neurovascular group. It is running in the ribs. Okay, there is an area called as neurovascular group. Just beneath the ribs, they are running. Now, if you are going to inject or if you are going to aspirate or put a needle in an intercostal space, the best way to put the needle, okay, the best way to put the needle is through the lower part of the space. Okay, through the lower part of the space, or in other words, through the upper part of the lower rib. So this is the lower rib. This is the upper part of the lower rib. So you can insert the needle close to the upper part of the lower rib or the lower part of the intercostal space so that you avoid injury to this neurovascular structure. Okay, so this neurovascular structures are prevented from injury. Okay, if you put a needle close to the upper portion of the lower rib or the lower part of the intercostal space. So this is the ideal place to put the needle. So let us see what are the options they are given. They are given lower border of the upper rib. If you put the needle through the lower border of the upper rib, okay, you are prone to injure the neurovascular structure. Upper border of the lower rib is the next best option which is given here. So this is the best answer for this question. Okay, this is the best option for this question. Upper border of the lower rib. Okay, fine. Yes. So we'll go to the next question with this. Okay, so here this is a simple straightforward question, no twist in it. Okay, no surprises in it. So what is the plane through which the red line passes through called as? Okay, so they have given a question like this, a picture like this, and they have drawn a red line, okay, through the highest portion of the iliac crest. I think this is what the students told me. Okay, they have drawn a line through the highest portion of the iliac crest, and they have asked what is the plane called as, or what is the vertebra that is related to it. See, if you see the abdomen is divided into number of quadrants by number of planes. Okay, so if you take the horizontal planes, the plane which passes through L1, okay, the plane which passes through the L1 is called as transpyloric plane. What is this called as? This is called as an transpyloric plane, and this transpyloric plane passes through the tip of ninth costal cartilage. Okay, it passes through the tip of the ninth costal cartilage. Okay, guys. Okay, it passes through the tip of the ninth costal cartilage. Below the transpyloric plane, okay, if you draw a plane through the tip of the costal margin, okay, that plane is called as a subcostal plane. This plane is called as what? This is called as a subcostal plane. It passes through the L3 vertebra and it passes through the tip of the costal margins. Okay, it is passing through the tip of the costal margin. Okay, below the subcostal plane, if you draw a plane through the highest most part of the iliac crest. Okay, so this part is the highest part of the iliac crest, and if you draw a line through the highest part of the iliac crest, that kind of line or that kind of plane is called as an supracrystal plane. This is called as an supracrystal plane, and the supracrystal plane passes through L4 vertebra. It passes through L4 vertebra. Okay, and if you draw a plane through the tuberosity of the ilium or iliac tubercle, then this line is called as a transtubercular plane. This is called as what? This is called as a transtubercular plane, and this transtubercular plane passes through L5, or sometimes it is through L4 L5. It is through L4 L5. Okay, so if they have given this red color line which is passing through the highest portion of the iliac crest, then the answer is very simple. It is supracrystal plane. It is supracrystal plane. Okay, so if they have given the plane passing through L1, then that is transpyloric plane. If it is through L3, it is subcostal plane. It is through L5, it is transtubercular plane. Okay, guys. So this is a simple, straightforward question. No twist in it. Okay. Now coming to the next question. A person had sustained injury to his neck, and following it, he was unable to shrug or elevate his shoulder. Okay, he is not able to elevate his shoulder, and is also having difficulty in turning his head. Okay, so if you see the neck region, okay, so the important nerve which runs in the posterior triangle of the neck. Okay, so if you consider, this is the iliac, sorry, this is the skull bone, or the base of the skull. You've got the mastoid here, and you've got the mandible here. Okay, so you get a important muscle here called as the sternocleidomastoid muscle. Okay, this is called a sternocleidomastoid muscle, and just behind the sternocleidomastoid muscle, you have another big muscle called as the trapezius muscle. Okay, and below that you have the clavicle bone. So this is clavicle. Okay, this is clavicle, and this triangle is called as what? This triangle is called as a posterior triangle of the neck. This is called as a posterior triangle of the neck. Okay, so posterior triangle of the neck. Okay, one important nerve runs from the anterior to posterior direction. Okay, this nerve which is running here is called as the spinal accessory nerve. This is called as what? This is called a spinal accessory nerve. Okay, this is called a spinal accessory nerve, a part of the 11th cranial nerve, and this nerve supplies, okay, on its way supplies sternocleidomastoid. On its way, it also supplies the trapezius muscle. Okay, so the main muscle which helps in shrugging of the shoulder or elevation of the shoulder is the upper portion of the trapezius. There is another muscle called as levator scapulae, which also helps in elevation of the scapula. But as shoulder elevation, main muscle is upper fibers of the trapezius. Okay, so for elevating the shoulder, okay, so it is upper fibers of the trapezius, upper fibers of the trapezius. Okay, and if you want to turn your head, the main muscle which helps in turning the head is sternocleidomastoid. When sternocleidomastoid acts, it tilts the head towards the same side and turns the head chin towards the opposite side. This is what the action of sternocleidomastoid is. So when a patient is not able to do this both, which means the nerve which is affected is spinal accessory nerve. So any injury in the neck or any procedure in the neck, like taking a cervical node biopsy, okay, or removing a foreign body from the neck, or incising a abscess in the neck, the nerve which is most commonly, or the nerve which is more prone for injury, is the spinal accessory nerve. Okay, when spinal accessory nerve affects, these two muscles get weak, so the patient will not be able to do the said action. So the answer for this question is spinal accessory nerve. You can argue, what about sternocleidomastoid? No. If sternocleidomastoid has got injured, the patient would have been able to do elevation of his shoulder. He is not able to do elevation of the shoulder, and he is also not able to turn his head. So the best option among this is spinal accessory nerve. Is spinal accessory nerve. Okay. Now coming to the next question. So this is a simple question again, guys. Okay, so here there is a maid. So she complained of pain and swelling in the knee. Which bursa is most commonly known? So this is called as an housemaid's knee. Okay, this is called as an housemaid's knee. The answer is very simple for this. This is called as housemaid's knee. Before going to the answer, let us consider what are the bursas around the knee. Okay, so there is a bursa above the patella. So what is this? So this is, okay, so this is patella. Okay, this is patella. Above the patella, you get a bursa. This is called as a patellar bursa. This is called as an suprapatellar bursa. Okay, this bursa is called as an pre-patellar bursa. This is called as an pre-patellar bursa. Okay, this bursa which you see here is called as an infrapatellar bursa. Infrapatellar bursa. Okay, and the one which is seen on the medial side of the tibia in its upper part is called as an pes anserinus bursa. This is called as an pes anserinus bursa, and this pes anserinus bursa is present between the pes anserinus tendon, also called as guy rope tendons. To name them, they are sartorius, gracilis, and semitendinosus. Okay, what are they? They are sartorius, okay, gracilis, and semitendinosus. So the bursa between them is called as a pes anserinus bursa. So now when an housemaid cleans in houses, she kneels down and cleans. So the most common bursa which gets inflamed is the pre-patellar bursa, resulting in pre-patellar bursitis. And this pre-patellar bursitis is the answer for this question. So the answer is option B. Now what about option C? So option C is seen in clergymen. Okay, those who kneel and pray. This infrapatellar bursitis are common. So that is called as an clergyman's knee. That is called as an clergyman's knee. Okay, so clergyman's knee, the answer is infrapatellar bursitis. Housemaid's knee, the answer is pre-patellar bursitis. Answer is pre-patellar bursitis. Okay, so without wasting much of the time, we'll go to the next question. So what is this? Which congenital deformity is shown in this image? Okay, we'll go to the image first. Okay, so here you can see a child image is given, and the posterior part of the skull is opened, brain is atrophied and exposed, the entire spinal cord is open. Okay, so skull is open, okay, and the spinal cord is open, and the spinal canal is open, and the spinal canal is open. Okay, so why this happens and what is this condition called? See, normally if you see, there are 3 layers in the germ disc. One is called as an ectoderm, next one is called as an mesoderm. So what is this? This is called as an mesoderm. The next layer is called as an endoderm. Next layer is called as an endoderm. This is called as an endoderm. Okay, this is called as an ectoderm. The outermost layer is called an ectoderm. See, normally what happens is the ectoderm thickens in the midline and forms an elevation okay, like this. Okay, so this elevation which is seen in the ectoderm is called as a neural fold. What is this called as? This is called as a neural fold, and this neural fold slowly close with one another, okay, and forms a tube called as a neural tube. So what is this called as? This is called as a neural tube, and this neural tube is opened cranially. Okay, so that is called as a cranial neuropore. That is called as a cranial neuropore, and it is open distally, which is called as a caudal neuropore. What is this called as? This is called as a caudal neuropore. Usually, the cranial neuropore closes by 25th day of the gestation. By 25th day of gestation, it closes, and 3 days later, by 28th day, the caudal neuropore closes. If suppose this cranial neuropore doesn't close, or the neural tube, if it doesn't fuse with one another, then the entire skull is open and the brain gets exposed. The head is not formed well. Then that condition is called as anencephaly. And that condition is called as what? Anencephaly. So the condition where the skull is open and the brain is underdeveloped, we call that condition as anencephaly. And mostly these childs will be born as stillborn babies. They will not survive. And if the spinal cord is also open, then it is called as an craniorachichisis. Okay, so that is called as a rachichisis. Along with that cranial, it is open, so it is called craniorachichisis. Okay, so if you see the option for this, the congenital deformity shown is not only anencephaly, it is also the spine which is opened up. So that is called as an anencephaly and craniorachichisis. Anencephaly and craniorachichisis. Okay, clear? If only the caudal part of the neural tube is not closed, then it results in conditions like meningomyelocele and spina bifida occulta. Okay, but when both the cranial and the entire neural tube is not closed, then it results in anencephaly and rachichiasis. Okay guys, see this is an embryology question. This is a picture which is taken from Langman's embryology. If you go through the embryology, okay, sure you can see this picture is one of the common question which is asked in the embryology. Okay, when you just go to the next part of the question. See, this is an again a straightforward question guys. A female had a delivery and post pregnancy she is complaining of pain in the anterolateral aspect of the thigh. Okay, so first we'll see why she is having pain on the anterolateral aspect of it. What is the nerve supply for it? So if you see the thigh, okay, let us consider this is a thigh and this is the leg portion. Okay, and this is the thigh and the leg portion. And what is this bone? This is patella bone. Okay, this is the lateral aspect of the thigh and this is the medial aspect of the thigh. Okay, the medial aspect of the thigh is supplied by, okay, the sensory for the medial aspect of the thigh is supplied by obturator. It is by operator. Okay, more anteriorly on the anteromedial aspect. Okay, on the anteromedial aspect, the nerve supply for the thigh is by the medial femoral cutaneous nerve of the thigh. Medial femoral cutaneous nerve of the thigh supplies the anteromedial aspect, and the anterior aspect of the thigh is supplied by, okay, it is supplied by another cutaneous nerve which is called as an intermediate femoral cutaneous nerve. Okay guys, please remember, medial femoral cutaneous nerve and inferior femoral intermediate femoral cutaneous nerve. Okay, medial femoral cutaneous nerve and intermediate femoral cutaneous nerve, both are branches of femoral nerve. Both are branches of femoral nerve. Okay, whereas on the lateral aspect of the thigh, okay, the thigh is supplied by a nerve called as lateral femoral cutaneous nerve. Okay, this is called as lateral femoral cutaneous nerve, and this lateral femoral cutaneous nerve is a direct branch of lumbar plexus. It is a direct branch of lumbar plexus, root value L2 L3, root value L2 L3. So lateral femoral cutaneous nerve thigh is a direct branch of lumbar plexus, and this nerve crosses the pelvis and enters the thigh. Okay, it crosses the pelvis and enters the thigh. So when a patient is pregnant, due to the pressure within the pelvic cavity, this nerve can get compressed, and because of that, the patient might have developed pain on the anterolateral aspect of the thigh. And if the patient develops paresthesia in this area, okay, if the patient develops paresthesia in this area, that condition is called as meralgia paresthetica. Okay, so the question can be framed like this: what is the nerve that is involved in meralgia paresthetica? So the nerve that is involved in meralgia paresthetica is again lateral femoral cutaneous nerve of the thigh. Lateral femoral cutaneous nerve of the thigh. Okay, so please be clear guys. Lateral femoral cutaneous nerve of the thigh is a direct branch of the lumbar plexus. It has a course from the lumbar plexus along the pelvis to the lateral side of the thigh. Okay, so it is prone for damage beneath the inguinal ligament within the pelvic cavity, resulting in a condition called as meralgia paresthetica. Okay, so the answer for this question is lateral femoral cutaneous nerve of the thigh. Okay, so we'll go to the next question. What condition is shown in this picture? Okay, so if you see this, this is a spotter question where there is an small bulge noted in the middle of arm. Okay, this small bulge is called as a pawpaw-y muscle. This is called as a pawpaw-y muscle. Okay, so this happens due to biceps tendon rupture. Okay, I hope you know biceps has got a proximal. If you see the biceps muscle has got a long head and a short head proximally, and it has got a tendon distally. Okay, so when the distal part of the biceps tendon ruptures, the muscle forms a small elevation. Okay, it shrinks back and forms a small elevation which is called as a pawpaw-y muscle, and that is due to biceps tendon rupture. That is due to biceps tendon rupture guys. It is due to biceps tendon rupture. Okay, fine. So the answer is very simple, and it is in front of your eyes. So this is due to biceps muscle rupture. And can anybody tell me what is the nerve supply for the biceps? What is the nerve supply for biceps? Yes, the nerve supply for biceps is musculocutaneous nerve. It is musculocutaneous nerve. It is musculocutaneous nerve. Yes, it is musculocutaneous nerve. Okay, fine. So sometimes a patient might develop bicipital tendinitis. Okay, bicipital tendinitis. Inflammation of the biceps tendon is called as bicipital tendinitis. So when a patient develops bicipital tendinitis, it can be clinically diagnosed by a test called a speed test. These are orthopedic questions. Speed test and Ergesen test or test for bicipital tendinitis or test for bicipital tendinitis. These are the important topics around the biceps tendon. I think this holds good for this discussion. Okay, so we'll go to the next question. So the next question is again a picture based question. Okay, so where a patient, a clinical scenario based question, where a patient had swelling below the ears and he complained of pain in the lobule of the ear, and he also has difficulty in closing his left eye, and he's also having difficulty in eating the food. Okay, so guys, please remember, okay, the patient has pain in the ear, okay, and he has got difficulty in closing his eye, and he has got difficulty in eating the food. See, if the patient has got difficulty in closing the eye, okay, what is the muscle that helps in closing the eye? The muscle that helps in closing the eye is orbicularis. Okay, that is orbicularis oculi. That is orbicularis oculi. And the patient has to achieve the food, okay, without any difficulty. Okay, so the orbicularis oris should act well. Okay, so orbicularis oris should act well. Okay, otherwise the saliva will drool out, the food can come out. Okay, if the person is not able to purse his lips. So orbicularis oris is important for it. And if you take the ear, okay, if you take the ear, okay, close to the lobule and close to the conch of the ear, the nerve supply for this is vagus nerve through the branches of facial nerve, through the branches of facial nerve. Okay, through the branches of facial nerve. Okay, so the facial nerve supplies not only this, it also supplies orbicularis oculi, it also supplies orbicularis oris, it also supplies the muscles of the facial expression. So muscles of the facial expression is supplied by the facial nerve. Okay, so when the facial nerve gets injured or damaged in the parotid region, the patient can have all this kind of symptoms. So the answer for this question is facial nerve. Okay, so guys, please remember, around the parotid region, these three nerves are seen. So don't get carried away by the options. So if the patient has got difficulty in closing the eyes and eating the food, straightforward, the answer is facial nerve. Okay, so if you see the parotid region, okay, if you see the parotid region here, so in front of the ears, you will have the parotid gland. Okay, it's an inverted pyramidal shaped gland. If you see the superior border, you will have a nerve. Okay, so that is the superficial, that is the auriculotemporal nerve. Over the skin, you have the great auricular nerve, and within the substance of the parotid gland, you have the facial nerve. So all the three nerves are seen here, guys. So you got the auriculotemporal nerve, you got the great auricular nerve, and you got the branches of the facial nerve. So all these are related to the parotid gland. So don't get carried away by the option. So look into the question, analyze the question, and do the answer. Okay, so the answer for this question is facial nerve. Okay, we'll go to the next question, guys. Okay, so what is the next question? Yes, so here is a cadaveric based image. Here is a cadaveric based image. A patient is suffering from aortic dissection. Now, injury to which marked structure in the image will cause hiccups. Okay, so here they marked a few structures here. Okay, so one structure is A. Okay, and the next structure which is seen here is B. Okay, and the next structure which is seen here is C, and the next structure which is seen here is D. Okay, so if you see this, this is a clinical question where the patient has got an aortic dissection and the patient also presents with hiccups. See, whenever a patient presents with hiccups, it is due to irritation of the diaphragm. It is due to irritation of the diaphragm. Okay, so it is due to irritation of the diaphragm, or it is due to irritation of the nerve that supplies the diaphragm. Okay, so nerve that supplies the diaphragm. Okay, so what is the nerve that supplies the diaphragm? The nerve that supplies the diaphragm is the phrenic nerve. Okay, what is this nerve? That is phrenic nerve. Okay, and if you see the mediastinum of the lungs, okay, you have a structure here called as the hilum of the lung. Okay, and in front of the hilum of the lung, you have a nerve which is running. And okay, so there's a nerve which runs in front of the hilum, and there is a nerve which runs behind the hilum. Okay, and the nerve which runs in front of the hilum is very close to the arch of the aorta, and the nerve which runs in front of the hilum is nothing but the phrenic nerve. It is nothing but the phrenic nerve, and the nerve which runs behind the hilum is the vagus nerve. Is the vagus nerve. Okay, if you see this diagram, you can see this is the root of the lung or the hilum of the lung, and you can see a nerve which runs in front of the hilum of the lung, and this is nothing but the phrenic nerve, and the nerve which runs behind the hilum of the lung is the vagus nerve, and this phrenic nerve is close to the aorta. So when the aorta enlarges due to aortic dissection, it can cause irritation of this nerve. So irritation of the phrenic nerve causes hiccups. So the answer for this question will be option A. Okay, option A. Okay, so this is a cadaver based question, slightly difficult question because it is very difficult to identify the structures in the cadaver. It is very difficult when we go to the dissection hall itself, and here it is more difficult. Okay, fine. So now coming to the 15th question, where bulla ethmodalis is located. Okay, so this can be an ENT question. We can consider this as an anatomy question also. So what is bulla ethmodalis? Where it is seen? Okay, if you see the lateral aspect of the nose, if you see the lateral aspect of the nose, the lateral aspect of the nose has got various shelf-like projections called as the concus. So these are called as the superior concha. Superior concha. Okay, this is called as an middle concha. Okay, this is called as an middle concha, and this is called as an what? This is called as an inferior concha. This is called as an inferior concha. See, the superior concha and the middle concha are a part of the ethmoid bone. They are what? They are part of the ethmoid bone. Whereas the inferior concha is an independent bone. This is an independent bone. What is this? This is an independent bone. Okay. So if you see the concus, beneath the concus, if you see beneath the concus, okay, there are depressions, and these depressions are called as meatus. Okay, so you've got three meatus. Okay, one is called as an in middle meatus, inferior meatus, and superior meatus. Now what I'm going to do is I'm going to erase the superior middle concha. I'm going to remove the middle concha. When I remove the middle concha, I can able to appreciate a elevation, okay, a bulge in the middle meatus, and this bulge is called as bulla ethmodalis. What is this called as? This is called as bulla ethmodalis. And why bulla ethmodalis is seen here? What is the structure responsible for this elevation? The structure that is responsible for bulla ethmodalis is the middle ethmoidal air sinus. Middle ethmoidal air sinus produces an elevation in the middle meatus, which is called as bulla ethmodalis. So middle ethmoidal air sinus is the structure which is beneath the bulla ethmodalis, and it is the one which opens over the bulla ethmodalis. Also beneath the bulla ethmodalis is a depression which is called as an hiatus semilunaris. This is called as what? This is called as hiatus semilunaris. Opening into the hiatus semilunaris floor is the maxillary sinus. Is the maxillary sinus. Okay, guys. So these are certain important areas to be noted here. So if somebody asks you, bulla ethmodalis is seen where? It is seen in the middle meatus. Okay, it is seen in the middle meatus. That is the right answer for this question. And if you somebody asks you, what is the structure that is responsible for bulla ethmodalis? Okay, that is the middle ethmoidal air sinuses. And if somebody asks you, there is an opening over bulla ethmodalis, and what is the structure that is opening there? Yes, the answer is again middle ethmoidal air sinus. Okay, so the questions from nasal cavity, questions from the meatal openings are very common. In the superior meatus, you got the opening of the posterior ethmoidal sinus. You got the opening of the posterior ethmoidal sinus. Okay. In the anterior most part of the hiatus semilunaris, you got the opening of the frontal sinus. You got the opening of the frontal sinus. In the inferior meatus, you have the opening of the nasolacrimal duct. You got the opening of the nasolacrimal duct. Okay, guys. So these are the important areas. Must know topic is this lateral aspect of the nose. Okay. When coming to the next question, is again an embryology based question. What is the underlying defect in the congenital deformity shown in the image? So they have given an image like this. Okay, they have given an image like this, and they are asking you what is the stage of development which has got affected here. See, here the child has got a well-developed cranial portion, well-developed body, but the caudal portion is not developed well. You don't see the lower limbs. So this is called as a caudal dysgenesis. This is called as what? This is called as caudal dysgenesis. This caudal dysgenesis is also called as cyrinomelia. This is also called as what? Cyrinomelia. Okay. And this caudal dysgenesis or cyrinomelia happens or occurs due to a problem in the stage of gastrulation. Now, what is called as gastrulation? Gastrulation is formation of three germ layers. Formation of three germ layers is called as in gastrulation. I hope you know what are the three germ layers. I don't want to repeat it. They are the ectoderm, mesoderm, and endoderm. The formation of three germ layers is called as gastrulation. Any defect during the gastrulation where the mesoderm of the lower part of the body, if it is not formed well, if the mesoderm of the lower part of the body is not formed well, then it results in a condition called as caudal dysgenesis. Caudal dysgenesis or cyanomelia occurs because of problem during gastrulation. So you don't see the lower limbs, you don't see the properly developed urogenital region. All occurs because of this condition. Okay. So if somebody asks you what is the underlying defect in congenital deformity seen there, the answer is gastrulation. Okay. It is the underlying defect, that is gastrulation. Okay. When coming to the next question, okay, at what time does the talus is formed? Okay, so this is a very simple, straightforward. If you know the answer, you can answer it well. Otherwise, it is very difficult. Okay, if you see the tarsal bones, okay, if you see the tarsal bones, guys, okay, so there are three bones. Okay, one is talus, another one is calcaneum. Okay, another one is calcaneum, and another one is cuboid. They ossify, okay, before birth. They ossify before birth. Okay, so these three bones ossifies before birth, and of this, talus ossifies by 6 month. Okay, it ossifies by the 6th month of intrauterine life. Calcaneum ossifies by the 9th month of intrauterine life, and cuboid ossifies by the 11th month of intrauterine life. All the other tarsal bones ossifies within 2 to 3 years of the birth. 2 to 3 years of the child birth, all the other tarsal bones, okay, all other tarsal bones will ossify between 2 to 3 years of age. Okay, so it is a straightforward question. If they have given this, at what time the talus is ossified, it is ossified by 6th month of intrauterine life. It is ossified by 6th month of uterine life. When you talk about tarsal bones, please also remember about carpal bones. None of the carpal bones appears before birth. Okay, before birth you don't see carpal bones. Before birth you don't see carpal bones. Before birth, no carpal bones. No carpal bones, guys. Okay, please remember, all the carpal bones ossifies after birth. Okay, at the first year of age, you can see the capitate which is forming and the hamate which is forming by the first year of age. By the third year of age, you can see the triquetral which is forming. Tri means 3, you can remember like this. Okay, if I put a symbol like this and convert into 4, then it becomes lunate. So lunate becomes the fourth bone to ossify at the 4th year of birth. Okay, and by the 5th year of the birth, okay, you have the scaphoid which is formed. All these are happening after birth. None of the carpal bones are seen before birth. Okay, and by the 6th year of age, you can see the trapezium which is ossifying, and by the 7th age, trapezoid ossifies. Trapezoid ossifies, and by the 12th age of the child, pisiform ossifies. Pisiform ossifies. So these are the ossification of the carpal bone, guys. These are the ossification of the carpal bone. So guys, please remember. So whenever a question like this comes, this is a straightforward question. Only when you know it very well, you can answer it. Otherwise, if you make a clue out of it, there is a high probability you will go wrong. So please remember the age of appearance or the age of ossification of the tarsal bones and the carpal bones. Any of this can come as a question in the other forthcoming exams. Okay, so please remember this. Okay, now a man suffered an injury on the head, and after this the blood is collected around the eyes. So there is an injury to the head. Now there is a collection of the blood around the eyes. Now collection of the blood around the eyes is called as a black eye. Is called as a black eye. Also called as a raccoon eyes. Is also called as a raccoon eyes. This is an I think we can also consider this as an FM topic, forensic medicine topic. Okay. Now, whenever there is an injury to the scalp, we should know the layers of the scalp. The layer of the scalp are: one is skin, next is the dense connective tissue, dense connective tissue. Okay, next is a dense connective tissue. Next is an aponeurosis. Okay, aponeurosis. The next layer is the loose connective tissue. Loose connective tissue. Loose connective tissue. The last layer is the periosteum or the pericranium. It's the pericranium or the periosteum. Now, if you see here, this first three acts as a single unit. Beneath the aponeurosis, you have got a loose connective tissue, which is called as a danger space of the scalp. Okay, it's called as a danger space of the scalp. And this is continuous with the periorbital region. This is continuous with the space around the periorbit. Okay, it is continuous around the space between the periorbit. Now, whenever there is a collection of blood or whenever there is an injury to the scalp, blood or hematoma usually collects in the loose connective tissue area and it slowly gravitates around the eye, resulting in collection of the blood around the eye, resulting in black eye or raccoon eye. Okay, so if somebody asks you what is the answer for this question, it is because of the loose areolar tissue which is forming the fourth layer of the scalp. So this is the fourth layer of the scalp. Okay, so above that the three layers acts as a single unit. Okay, so usually there is a potential space in the fourth layer where hematoma can get collected, and if it gravitates around the eye, then it results in black eye or raccoon eyes. Okay, fine. So with this we'll move to the next question, guys. We'll move to the next question. So this is the, I think, yes. Okay, so what is this image which is given here? See, this is an clinical question. Okay, so if you answer, if you know this, you can. It's a very very simple question. You can answer it straightforward. If you see here, if you see the arm is directed here, and the forearm is directed more laterally. Okay, so there is an deformity which is happening at the elbow. Okay, so if you take elbow, we call elbow as cubitus, and distal to the cubitus is the forearm, which gets deviated laterally, lateral deviation. Okay, we call it as an valgus. So this is called as a cubitus valgus condition. Where cubitus valgus can happen, it can happen due to non-union of lateral condyle of humerus fracture, non-union of lateral condyle of humerus fracture. Okay, if there is a medial condyle of humerus fracture or a supracondylar humerus fracture, supracondylar humerus fracture, usually it goes in for malunion. When the supracondylar humerus fracture goes in for malunion, it results in a deformity opposite to it. Okay, so the forearm will become a gun-like. Okay, the forearm will become a gun-like deformity. So this is called as a gun stalk deformity. And this gun stalk deformity is also called as cubitus varus deformity. This is called as a cubitus varus deformity. When cubitus varus deformity happens, it can be corrected by an osteotomy called as French osteotomy. It is corrected by an osteotomy called as what? It is corrected by an osteotomy called as French osteotomy. Okay, French osteotomy. Okay, so these are the important things around the deformities around the elbow. So the deformity which is given here is a straightforward question, clear-cut question. The answer is option A, which is cubitus valgus. Okay, so I think yes, this is the last question, guys. I think apart from this, they've asked one more question. I think one of the student told, see, there is a layer which is missing in the esophagus. They have given a histological picture of the esophagus. Okay, they have given an histological picture of the esophagus. Okay, and after giving that, they have given the option like mucosa, okay, submucosa, then muscularis layer, then you got the serosa layer. Okay, you got the serosa layer. Now they are asking what is the layer which is missing in the esophagus. Okay, see, in esophagus, mucosa can be seen, submucosa can be seen, muscularis can be seen. Since most of the esophagus runs in the thoracic region, the outermost coat is not serosa, instead it is adventitia. Instead, it is adventitia. Okay, so the fourth layer of the esophagus is adventitia, and that is the missing layer. And if they're given an histological picture of the esophagus and they've asked what is the layer which is missing, then the option is serosa for it. Then the option is serosa for it. Okay. So guys, see, the questions are very, very simple, guys. This in this year, the questions are very, very simple. It's a little bit clinical oriented questions. Otherwise, they are frequently asked topics, simple questions. If you have read well, you would have done well. If you have not done well, please read well for the future exams and do it well. Okay. So all the best, guys. Thanks for your patience listening.